So it is my pleasure to introduce and welcome everybody to our webinar today on AI and peripheral nerve MRI, and from acquisition to reconstruction and clinical interpretation. And as I mentioned, we have an outstanding group of speakers, panelists, and moderator, and it's my pleasure to introduce them. So starting with our first speaker today will be Mark Labelle, who is a principal AI scientist at GE Healthcare and also a adjunct assistant professor at the University of Calgary. Dr. Labelle received his PhD in biomedical engineering from the University of Alberta before completing a postdoc research fellowship at the University of South Carolina. He was critical in developing a deep learning reconstruction model that helps to really clean up and remove noise from MR, and then also while preserving full fidelity and intrinsic spatial resolution. So Dr. Labelle is an expert in this area, and we're very excited to have him here today. Our second speaker will be Dr. Exum Tan, who received his PhD in biomedical sciences from the Mayo Clinic. And then prior to his current role as an associate scientist and co-director of the MRI lab at Hospital for Special Surgery, he was a principal scientist at GE Electric's Research Center. Dr. Tan is a multi-PI and co-investigator on several NIH grants and looking at high-performance MRI gradients in the compact head-only system. And we are fortunate to have Dr. Tan as a member of our education committee as well. Dr. Dale Sneed will be joining us as a panel expert. He's a radiologist at Hospital for Special Surgery, director of MR neurography, and vice chair of MRI. He completed his undergraduate studies from Brown University before going on to complete med school at Albert Einstein. He also completed a residency at Brigham and Women's Hospital in Boston and a fellowship at HSS. Obviously, Dr. Sneed's research interests are sports spine and peripheral nerve MRI. He's a world leader in MR neurography, member of the GNF Research and Education Committee. And again, we're very fortunate to have him here today. And moderating this panel will be Mr. Ashley Simpson, who is a peripheral nerve surgeon at the Royal National Orthopaedic Hospital in the UK. Dr. Simpson completed his medical degree at St. John's and before receiving advanced training at the Perth Sports Surgery Fellowship in Australia and also the Upper Limb Fellowship at Guy's and St. Thomas's Hospital. He is faculty on several leading surgical training programs, specializing in brachial plexus and peripheral nerve injuries. He's authored over 40 peer-reviewed publications, and again, we're really fortunate to have him as a member of our education committee within the GNF. So with that, I will turn it over to Dr. Simpson.
Thank you very much, Stephen, and welcome everybody from around the world. This is a fantastic opportunity to try and talk about some ideas which are impacting us across the world in different aspects of our clinical life and also our personal lives. But this webinar is going to focus on both a conceptual and practical view on artificial intelligence in imaging, with a particular focus on MR neurography and what this may mean for peripheral nerve practice. So we're going to begin with the fundamentals, move into the clinical application, and then we'll finish the session with a panel discussion where we invite you as viewers to put your questions forward, and we'll try and address as many of those as possible. Before we start, we have a couple of poll questions which are going to pop up on your screen, which will hopefully give us a better idea of your thoughts on imaging and artificial intelligence role in this. So if you don't mind answering these, we'll just give you a few seconds for each question, and this will hopefully help guide discussions a little later on. So the first question, what is the biggest current barrier to the adoption of AI in nerve imaging? Please put your thoughts forward. Okay, should we move on to the second question? Oh, we got some answers first. So a pretty even spread across data, workflow integration, governance, cost and resources. So maybe we can delve into which of those is impacting us both in the US and the UK later, and maybe across the world. The next question, do you in your own practice have access to MR neurography? It's a fairly limited resource at the moment, but let's see what the viewers have access to. Right, shall we see the results of that? Okay, 42% having use. Wonderful, and we'll delve into why that is and what are the restrictions later on. So let's begin. We'll start with the fundamentals, and I'm going to move over to Mark Liebel, who's going to be outlining some background on AI in image acquisition and the implications of nerve injury. So, Mark, over to you, please.
Great, thanks so much. I am sharing my screen, so please somebody notify me if you cannot see it. But it's a pleasure here to be speaking to everyone today. I will be talking about the use of magnetic resonance imaging, particularly AI, for advances in neurography. If it wasn't obvious already, quick disclosure that I am an employee of GE Healthcare. And sort of as an effect of that, I will be naturally showing images acquired with GE equipment and describing GE exclusive features. I'm not targeting this as a kind of a commercial sales pitch. And a lot of other vendors do have comparable techniques. And the concepts that I apply, although demonstrated through GE equipment, should be available through other vendors as well. So just approach that with the correct lens. Most features are commercially available, but there will be a few I talk about that are pending regulatory approval, and I'll try to call those out specifically as I get through them. As I was putting this talk together, there are a bunch of topics that I wanted to touch on. And I decided to kind of have a restricted set of those because in the time allotted, I just can't get through everything. So what I'm going to talk about is like why use AI and actually why not using AI, challenges with nerve imaging, which will motivate the use for AI in image improvement and also scan time reduction. There's a lot of other additional topics here for AI and how it can impact the neurography workflow, but they're both a little bit less mature and just not quite enough time today. So these topics created out here, I won't be touching on, but I'm happy to discuss in the panel discussion. Okay, so kind of getting into this, why use AI? And because fundamentally, the quick answer is that it can solve problems that have historically required humans, and more importantly, problems that are very difficult to program with conventional methods. And shown in that diagram in the top right is a figure from the late 90s, and it's actually kind of one of the first modern architectures that we would still be seeing in use today in a very, very comparable, similar form. And the key elements here are that this is allowing a computer to search for patterns, lines and curves in the data that might together, when taken with other features, represent certain characters or patterns that you want to recognize and translate that to information. But a really key element here is not just finding patterns, but ignoring irrelevant information. It's this whole onslaught of stuff. It's like ignoring the static and picking out what you really want from a relevance in a particular problem. Another element is that you learn from examples, not hard programming, and you can generalize to similar new but previously unseen cases. Why now? Like, this AI has really exploded in the last almost 10 years. Why? What was the factor that sort of triggered that? And to me, it was sort of a convergence of technology. One is the hardware availability, commercial GPUs that are affordable. So the compute hardware really escalated. Availability of open source software packages like PyTorch and TensorFlow in particular, but also a little bit of development in theory, in particular the appreciation for the importance of nonlinearities in why AI works. And the reason, just to kind of give some intuition here, is that nonlinearities are super important because they let you ignore things. A really common nonlinear elements in AI and deep learning pipelines you'll see are these ReLUs, or rectified linear units. They're really simple. All it does is takes whatever input is being provided and either it basically nulls it out if it's negative, or just lets it pass through if it's positive. And this is really important because you can now really ignore things that you don't care about. And there's really a biological analogy of a neuron where you don't have an activation until you have enough inputs that add up and you cross a threshold, and at which point the neuron will fire. So there is a bit of an analogy in biology for why this is important. And this allows you fundamentally to pay attention to things you care about and ignore things you don't. And that was really, to me, a fundamental advance that enabled AI. So why not use AI? And just intuitively, it's actually, I think, because it had really horrible failure modes. And this leads to sort of a trustworthiness portion of it. And just taking an example of this MNIST handwritten digit classification, which is really the kind of like simple starting point that almost everybody will begin who is starting to do AI development. And with almost no effort, you can outperform human performance in classifying these digits. So in this case, you see a 4. We all know it's a 4. The algorithm tells us with perfect 100% probability that this is a 4. Excellent. No problems at all. However, if you do something simple, like just invert the contrast of this image. So imagine this radical concept of white paper and a black pen. Suddenly, you are telling me that it is a 2. And this is because the algorithm was not trained with this contrast. It was all black background with white characters. But the problem is that this is telling me it's 2 with 100% probability. And same here, this digit doesn't even fall into the set that it was trained with. But again, it's telling me that this is like a 7 with a very high probability. And these are really serious and completely undetectable failure modes if we don't see these input images. If we just rely on the output, we have no idea that this is happening. However, these are fully preventable with proper design, which really leads me to say that skepticism is reasonable. And you should approach these with skepticism and ask questions about how it works. Not all algorithms are trained equally, but also conversely, not all algorithms fail horrifically if they're designed properly. And I'd like to claim that this does design or guide our design philosophy for how we approach AI problems. We do see AI as sort of everywhere in the MR workflow, everywhere from like when the patient requisition comes in all the way through from reporting. There's a lot to do here, and we had to have a bit of a targeted investment in strategy in developing this. What this meant is we really focused on AI features that impact the scan, so image in particular. How can we make the images better? That's really the core part of what we want to produce and focus our efforts there. And there's been a concentration of features that have come out in this area, and it's probably the most mature. A second priority was how can we change our processing, visualization, segmentations, analysis techniques for images. That's really been the second priority and is maybe the second most mature area. And the third set is to kind of complete out this portfolio. Things from when the patient arrives to streamline workflows, but then also the clinical reporting. These are kind of the third tier applications that we've sort of focused on, partly due to either a little bit lower impact on the plan and prep side, or just extremely, extremely difficult on the reporting side with really high clinical implications. So we're going to be going in all these directions, but we've really concentrated in particular on the scan, and that's where I'll focus mostly on this today. There are some really big challenges when it comes to nerve MRI. The first is coverage. You may have some sensation or issues with nerves, but you don't know where that is occurring. It could occur really anywhere from the fingertips all the way back, all the way up to the brain, essentially. And so that requires really large field of views. We also, at the same time, need really high spatial resolution in order to actually see the detail and some of the smaller subtle features in these nerves. We need really specialized contrast weightings, and in particular, vascular suppression with nerves occurring very close to vessels. How can we actually make sure we see the nerves clearly? These are also, once we have this information, how do we visualize it all? There's a lot of complex tissues. There's complex trajectories of nerves. How can we present this in a way that is putting all this information together in a usable way? And this leads to a couple of challenges in the MR workflow, starting with the need for these large field of views and high matrix sizes, specialized contrast weightings. This inevitably leads to long scan times and relatively low signal to noise ratio. Again, those will cascade through, and the long scan times tend to lead to more artifacts. Motion, flow, chemical shift artifacts are all exacerbated. This triggers then a difficult image interpretation, leading to inconclusive, incorrect reports, and ultimately coming back to the patient where they may be receiving suboptimal treatment. So how can we address these elements to improve things? And AI at this point in time is playing a pretty big role in solving some of the issues. Long scan times, signal to noise, artifacts, and it's kind of moving now into the interpretation of these images.
Be something that was brought up just in that talk, which is how AI is impacting every step. Because nerve injury is a super heterogeneous group, both of injuries, patients, where you're scanning, etc. So maybe this to Daryl and X soon. Does this create unique challenges when you're trying to sort of create the robust AI models, either for the scanning, the image acquisition, or later on the producing of a report?
Truly, I
Thank you,
think this
Carol.
is something that the vendors early on recognize is that they need to create tools that would be applicable across a wide source of anatomies and different contrast weightings. From the interpretive side, though, it's difficult to create, I would argue, a tool that can target all the anatomies similarly, since there are different trajectories of the nerves, different calibers of the nerves, and different injury patterns. So it's certainly, it's a challenge. I think what we recognize, we're just thinking about the diagnostic side of things, but that's certainly a challenge that we'll have to face going forward.
So continuing on here, what we are doing is essentially using the data that we've acquired to make a better image. And if you look in a typical acquisition, we will acquire in the Fourier domain. So we're acquiring the data that you see down in the bottom portion. And this will then be used to make an image like you see in the top. A couple of typical things that happen in MR images is to get this Gibbs ringing or truncation artifact that occurs at high contrast boundaries, which looks like a bit of a ripple near edges. You also have noise throughout the image. And this obviously causes challenges, and we don't want to present images with too much noise or too much ringing. And a conventional reconstruction would actually then filter and smooth these out, essentially try to blur them out. But this also impacts the detail in the image that you care about. And we've developed algorithms that don't directly smooth the data you've acquired, but rather they will estimate higher resolution data to support what you actually have acquired while doing noise reduction everywhere in this data. So what you see in this phantom, so essentially ball of water with some structure put into it, is the images are very, very clean. There's very little noise, but also the ringing at these edges is more or less gone. And you can see that from the line profile, where the red profile stays higher for longer, drops off lower, and stays flatter, and there isn't this ringing around the edges. A really key component of this feature, though, is that it has to be really generalizable. It has to just always work. The point of doing imaging is not to know what you're imaging in advance. We don't necessarily know, so it has to work for any anatomy and any pathology. And same with contrast weighting. We can change the contrast weighting in MR quite easily, and we have to be able to work in essentially any contrast weighting environment. So generalizability to any patient anatomy, field strength is a core element of this feature design. So this also naturally then has applications to neurography, where we really need the benefits that this offers. This is a slide from Dr. Sneed at HSS. And one of the first times that I got really excited about this method and some of the clinical potential. The conventional protocol on the left is about 1 minute 10-second scan at a fairly typical resolution. And you can see the tibial nerve pointed out. The same data, when reconstructed with this reconstruction algorithm, you start to see a lot different structures and more detail inside that nerve fiber. And having the foresight to recognize some of the anatomy and actually then acquire a higher resolution image to confirm what that is, spending 4 minutes to get a higher resolution scan, we can confirm that that is real anatomy. So from the same data, we're able to really squeeze out quite a bit more information from that image. And just as another example, the detail that you're able to see now inside these nerve bundles is just simply a lot sharper. So in addition to being able to see more, we can use this technique when you have more signal to noise ratio to convert that into a reduced scan time. If you want to be able to get through an exam quite quickly, we're able to get scan time reductions by about a factor of 2. But a technique, an application of this that I really like, although this isn't nerve, but it can apply exactly to nerve as well, is to use higher resolution. So on the left is showing a conventional 3mm slice thickness acquired in about 3 minutes. And on the right is a thinner slice, so 1mm, so a little bit longer scan. But that additional reduction in slice thickness is allowing the visualization of residual pituitary tumor, which cannot be seen on a conventional protocol. So in this case, using this feature to improve the resolution at a very small change in scan time is absolutely completely changing the diagnosis. This also works for 3D imaging, where the benefit occurs in all 3 directions. This obviously has an impact in neurography, where conventional images, conventional reconstruction methods, you are seeing a lot of gray in the background here. There's a lot of noise that's sort of pushing through that sort of impacts your visualization of the nerve, impacts understanding where it is compressed, and you have either low or bright signals. if you take the same sort of data and reconstruct it with AirRecon we have a lot cleaner background. So the background noise is reduced, which means in these really low contrast noise ratio regions, we can start to see the nerve fibers. And you can really start to appreciate the difference in signal intensities more accurately across that nerve. We're able to do large field of view brachial plexus imaging, again with high contrast, high field of view, high resolution using this technique. So this has been a bit of an enabler for being able to do this, and we're able to start to see the nerve constrictions fairly accurately. This has really led to a reasonably comprehensive neurography suite that has several 3D imaging sequences that are designed for imaging nerves, cube stir and Mensa nerve, both two different 3D techniques, which are going to highlight the nerves. Mensa nerve will be better at vessel suppression, but both of them will pick out some of the vessels. We're currently extending this to a technique that we call osteo, and this isn't directly for nerve imaging, but is a really complementary method. This technique is a 3D radial method, and it's designed to help really pick out bone, but it does that by trying to separate bone from other tissues like tendons, ligaments, and other tissues that we can see, typically like muscle and fat. What happens is you have an excitation pulse, so we sort of initialize the signal, but you start reading out the data right after that, before the signal from these short T2 star species has disappeared, so we can still see them. After a contrast inversion, it looks a little bit like a CT. There are some challenges. SNR efficiency and artifacts, specifically fat water artifacts, are really problematic. And you can see that here. All these little squiggly lines are fat water interfaces. And they're so severe that it really does make the depiction of a lot of the bony structures, it's almost illegible. To me, I can't really decipher what is in this image. But we've found a way to really fix this problem. And we've invented a novel approach to add on to AirRecon DL for this method specifically, to not only deal with the noise, which is much improved if we take the typical denoising approaches of AirRecon DL, but it is also now able to correct for these chemical shift artifacts, and we have something that now looks a lot like a CT image. This is really, the utility is really being confirmed both in quantitative scoring, where we're seeing lesions the counts are approaching what we can see on CT. So we're seeing about 91% of bone lesions compared to the non-AI version of this image. And also qualitatively, it's much superior in terms of overall image quality, lesion conspicuity, and chemical shift artifacts are reduced, which on this score rubric is improved. What this has done is it's giving us sort of a comprehensive way to approach neurography, where we can take these GeoMR bone images, which look a lot like CT, have high spatial fidelity, use that understanding bone structures, use our cube stir events and nerve, visualize the nerve, combine these, and we now have tissue and bone visualization, which can then start to visualize or even print 3D models. And we've heard of a company called Axe 3D, developed digital model, also the 3D model. Have some nice benefits. It really everything down sort of in one spot. Hopefully, the move coming across the webinar, but you can see vascular in red and blue, and there's some yellow bone fractures in white. Right with this model, the surgery, you can really see the nerve beginning to impinge on that structure.
Sorry, Mark, you're just muffled again. I think it's the video running.
All right, I think I have a reason for requesting a new computer here. Is that better? Hopefully
Yes.
you can hear me. Okay. So just finish up talking about how we can go faster. We can use everything a little bit faster, but we also have a new technique called Sonic DL for going quicker. Again, it's compatible with many different sequences with applications in neurology. The way it works here is that we're going to actually acquire a whole lot of data. So this data we're acquiring, we just don't sample all of it. What we want to do is at the end of this process of this reconstruction is still obtain an image that is diagnostically viable, but acquired in a lot less time. And it is compatible with the technique I was just talking about. So now we can achieve really, really fast scans and really high quality scans. Again, a really key component of this technique that it works everywhere. Videos. The key component is that it does work everywhere. I'll try to turn the video off so that my audio isn't muffled. But generalized generalizability is a critical component here. It has to work everywhere and all the time. And again, this technique can be used for increasing. Okay, I'm just going to pause the videos. Hopefully they work. This technique can be used for increasing spatial resolution in a similar scan time, or can be used to reduce the scan time, depending on the application you want. I won't play the video just for bandwidth issues, but hopefully you can appreciate that a scan with a 1 millimeter isotropic resolution in 3 minutes versus a 0.6 millimeter isotropic resolution in just a little bit more scan time, the ability to visualize the nerve roots here is it's considerably improved. And I'll just finish off with one last kind of picture here where the ability to, again, see inside some of the nerve fibers using this technique, higher spatial resolution, is really enabled by the combination of these acceleration techniques and image quality reconstruction methods. So hopefully I've demonstrated that AI has a big role to play in the image acquisition and reconstruction elements, and that neurography has been a beneficiary of these technologies. And looking forward to the discussion that we have in the panel.
Fantastic talk, Mark. Thank you very much for that. And really interesting to see, at each stage how this is impacting it. A question, really from my own perspective, what do we need in our institutions in order to implement this? Is this technical ability? Is this personnel? Is this the programming side of things? What are the main things required?
Well, the techniques that I have shown are, for the most part, commercially available. And one of the really key features here that we want is to make this really easy. We don't want there to be a barrier to entry for this. And so, honestly, enabling these technologies is absolutely trivial. There's like a drop-down menu where you essentially turn it on. You have the ability to adjust, for example, the denoising strength from like a low, medium, or a high. That's sort of a preference. But beyond that, it's really straightforward. And the idea is that it should be, from day one, something you can just use right away. And I think one of the bigger challenges we face is the interpretation, just people becoming familiar with it. Images look better, they look different, but people are almost familiar with bad looking images, and just overcoming familiarity to recognize that there's a lot of improvement here.
Thank you very much for that. So we'll move on now. We've heard about the broader framework to Exun, who's going to talk us about moving those principles into practice and some deep learning applications in MR neurography. So Exun, if you'd like to share your screen and go for it.
Sure. Can everyone see my screen? Give me a thumbs up. That's good. And I can sound fine. So thank you so much, Ash, for the kind introduction, and to Stephen and GNF for inviting me. I just want to focus more on the applications of deep learning on MR neurography in this section. So these are my disclosures. So I'll just briefly touch on why we want to perform MR neurography, just very briefly, and then I'll go on to talk about the potential applications for deep learning, really focusing on the image quality improvements and then the automating 3D nerve visualization. So why MR neurography, at least in our practice, is an important adjunct to electrodiagnostic testing that includes nerve conduction studies and EMG. MR neurography is helpful for localizing the nerve injury, especially when it's multifocal or fascicular in nature. It can influence the surgical planning and outcomes, and provides a global assessment of nerves and the muscle. For instance, in this example, in the Parsonage-Turner syndrome, we're able to visualize constrictions of the suprascapular nerve that innervates the supraspinatus and infraspinatus muscles, and visualize the denervation from there. In terms of localizing the pathology, being able to understand the impact, for instance, in this constriction in the fascicular bundle in the AIN, and being able to look at these in 3D and also in 2D, and then be able to correlate that with surgical findings, and then understand the improvements to the outcomes. So that's been very beneficial. So what are some of the potential applications for DL in MR neurography? The first is to triage, for us to understand which nerves to image and how to best image these nerves for the given time, resources, or the magnets that you have. The second, as Mark has expanded on comprehensively, is in terms of the image acquisition. So improving the image quality, the spatial resolution, and also the scan time. And also, on top of that, to recognize nerves, to help images to do that, because it's not necessarily something that is very easily seen all the time, so that we can plan the acquisitions to obtain the right scan planes and the spatial resolution needed for interpretation, and also for the end user, the surgeons, and our referrers. The next application is in terms of image interpretation. So one that you may have seen commonly heard in the news is related to lesion detection. So in our cases, looking at neoplasms, injury, and also inflammation. And then to somehow fold that in towards improving or to automating diagnostic reporting. The last aspect is in terms of pre-op planning. So I think Mark has already alluded to that we can perhaps use AI to automate segmentation, not just for nerves, but also for bones and also for blood vessels or any other critical anatomical structures that will be important for surgical planning. And perhaps also to automate measurements that will be of importance. For instance, trying to provide the surgeons with measurements from nerve to bone, bony landmarks. I will just be able to have time to focus on two of these applications in this talk. The first is in terms of improving image quality. So as compared to conventional images, we've been able to routinely apply deep learning reconstruction to improve the image quality for the same given scan time. And this is just one example from vendors and one of the vendors. And as Mark has said, this is now commonly available among different vendors and it's not specific to one. This is just one example. And there are also improved versions that are coming up, for instance, with Sonic DL, shown by Mark before, being able to visualize the nerve fascicles better with higher spatial resolution for the same given scan time. We have used DL image reconstruction routinely in our practice with Dr. Sneak, and in this example, in the lumbosacral plexus, and being able to visualize the nerves much better and to look at the fascicular architecture for the same given scan time has been tremendously helpful. The next application, which I'll touch on a little bit more, is in terms of image segmentation. There have been many different examples and also commercial offerings by startups and to look at muscle segmentation, providing more comprehensive analysis of muscle health. These are just two different companies that have these offerings. In terms of nerve segmentation, however, I have yet to see a commercial offering, but there's certainly been many research attempts to try to segment the bones. These have mostly been limited to the larger nerves in these two examples in the sciatic nerve, because this is one of the largest nerves that we can confidently segment for research purposes. So what are some challenges in deep learning nerve image segmentation? I think the main problem, as alluded to in one of the posts earlier on, is the lack of data. So lack of data sets, especially for three-dimensional MR neurography. The nerves in general are much smaller than muscles and larger organs in the body, and they can be mistaken for other structures such as blood vessels and entheses. There's also anatomical variability in terms of the connections, the branching, and also deviation of the expected nerve course following an injury or surgery. So how can we provide automated, accurate 3D nerve segmentation? That's still an open question, but if that was available, what could we do with that? Here is an example that's just following what Mark LaBelle has showed previously. We can combine MR neurography with volume rendering and also bone MRI, for example, using the ZTE osteo methods, and then put these renderings together to be able to provide an appreciation of the anatomy, the point of the injury or the inflammation or impingement, and also use that for preoperative planning. And we have shown this in multiple different cases, for instance, in this median nerve tethering post-fracture as well. You can see over here. So if this was possible, then one possible workflow we could use is to first do a very high resolution and high quality MR neurography along with bone scans. Perform this automated nerve segmentation, for example, showing the impingement from a thoracic outlet syndrome and also hyperintensity in the brachial plexus, and provide automated visualization or a faster way to 3D print these models, and also to provide a nerve by nerve analysis. So perhaps these kind of automated analysis would provide further insights, especially if we're able to aggregate large data sets together. Just some closing thoughts to share. Deep learning techniques can enable high quality imaging and perhaps broaden the adoption of MR neurography. DL segmentation of nerves and perhaps other DL applications may be feasible, but currently, in my opinion, we lack high quality data sets to be able to train these deep learning networks. There are many potential applications in MR neurography, including 3D visualization for preoperative planning and perhaps for interpretation as well. And with that, I'll just thank my lab, my colleagues, and I'll turn over to Ash for questions.
Thank you very much, Exun. I think you and Daryl are really sort of leading in this field at HSS. It's amazing to see this work. A question I have is something Mark alluded to earlier, which is we're seeing MRI in more detail than we ever have done before. And radiologists are not used to seeing this detail, especially with nerves and nerve pathways. How are you going to train radiologists to pick up on these now sort of subtle injuries that you're going to see in sort of high definition?
That's a great question, Ash. One is to train the technologists in terms of being able to acquire these images and to know where these nerves are. So that I think is one of the first things that we can do. Perhaps with automated segmentation, we could identify these nerves as the technologists are scanning. Then in terms of interpretation, I think the same tools can be used as well, being able to highlight these anatomies for radiologists to identify and slowly improve the training from there. And I think one important thing that you alluded to in your question is that the spatial resolution keeps improving. So as the MRI vendors provide us with new techniques, then we may need to continue to train more data sets to improve the database of nerves that can be recognized.
That's wonderful. Regarding those data sets, do you think there's a role for a sort of a widespread collaboration in trying to build a registry of these data sets? Because otherwise, if we're all training our data sets independently in our own little centers, we're going to find that they're not applicable to different populations and such like that.
That's an excellent insight. I think getting these data sets and being able to share them, perhaps enabled by the GNF or some other body to be able to come together and share these data sets will be very important.
I think that's a great idea. Maybe that's one for Stephen to look at. Right, so we will move on to the panel discussion, and I'll invite Daryl in here as well, who's going to help lead this with me. Daryl, do you have any questions for the panel so far?
I think just a general question. So one question I often ask at AI symposiums and so forth is, there's different aspects of AI, and particularly with regard to the interpretive side, which we haven't touched on as much, which I think may be the hardest to tackle. But if we were to tackle that, how would, maybe a question for Mark and Exun, how would we be able to integrate different applications or programs? So for example, if we had a program that we're able to detect an hourglass-like constriction, Parsons-Turner syndrome, another algorithm to detect nerve discontinuity, say a case of laceration or a gunshot, And then another, model to evaluate muscle denervation. Those applications in and of itself could be pricey. And how do we integrate all those together? Where do you see the future of that? Maybe Mark, if you could
Mhm.
tackle that.
Well, I mean, again, coming at this from the lens of a vendor, we want to make things simple for people to use and intuitive and also available. And people who want to use these tools are generally not going to want to have to go out of their way extensively to use them. Clinicians are very busy, which means we generally have to have some sort of integrated workflow that's going to combine those techniques. And also the combination of techniques in one place is usually quite helpful because there's usually synergies. And both Exun and I showed how you can start taking different image contrast weightings and then building the 3D models, but you need all that in one spot. So I do see a role for vendors like GE Healthcare in terms of trying to get these models and all put together in one platform. The challenge, though, is that we aren't really in a great position to necessarily build all of those analysis tools, which means we do need to partner with a bunch of other people to get data, to get algorithms, to get ideas, to get the clinical expertise to help build those. So I don't think there's a really complete answer, and that is definitely a challenge to do. But I do think the key at the end of the day, it has to be easy for people to use, has to be in a workflow, and has to make sense.
Exun, do you have anything to add to that?
I think Mark said it very well. Um, I think over time, I think the vendors and also the picture archival communication system vendors would be able to, and I believe they have already started to be able to offer ways for different startups to be able to use these deep learning applications in their workflow. So I think these things will come. I think the more important thing to me is still getting the data sets and being able to update the data sets with more high quality data so that we can continue to push the boundaries of what we can do.
Great. I'm going to move to some questions from our viewers. So first one is from Noah. We do a lot of nerve transfers in tetraplegic patients where one of the most critical parts is determining which potential recipient targets are time dependent and are exploring the idea of evaluating muscle MR characteristics as an adjunct to our methods of determining HTE presence of an LMN injury. Would we be able to automatically segment small forearm muscles to this effect? Daryl, do you want to go
Sure,
with
I
that
could
one?
try to tackle that. Yeah, so that's a great question. I think the couple of companies or vendor offered products that Dr. Tand briefly showed in his talk have largely focused on larger muscle
Mhm.
groups because those are easier to segment. So the
Mhm.
rotator cuff musculature, the hamstrings, particularly in the lower leg. And I think what Exun and I saw early on with a project that we were doing in a longitudinal cohort of patients with inflammatory neuropathy was trying to look at denervation patterns in the forearm, and indeed is challenging to reliably segment all those. So I think that would be a very useful tool. I do think I'm sure that people are working on this. Something that we had to in this cohort of patients we had to do manually. It was quite tedious, but I don't see an absolute barrier to be able to perform that. I think it comes down to the quality of the initial data to train on. So you're able to confidently separate out the different muscles from each other, because I think what's important is not in the setting of nerve transfers. You're not looking at muscle groups. You're not interested in the entire bulk of the flexor mass or the extensor mass. You really need to know the integrity of each individual muscle, and that's why the muscle segmentation can be important. So I think you need to use sequences again that clearly outline different muscle boundaries. Just to expand on that, this is I think a tool that we could use. And I think one of the barriers to developing AI tools comes down to cost. So who's going to pay for this? Who's going to, even if you're able to develop it, and who's going to be able to use it? Are there codes that will be, I've heard of, codes that maybe that will be available in the future to use these AI tools. But initially, can a center, simply just purchase the software program for somebody able to create it?
In response to that, Daryl, obviously things move so quickly in AI. Once you've trained a data set on, a specific protocol, what happens when your next protocol totally supersedes that, gives you far better images? Do you need to start training another data set, or can you sort of transfer that across?
It's a great question. I'm going to defer that question to Mark because I think, Mark, you probably deal with
Mhm.
that on a daily basis. Is as the imaging
Mhm.
techniques improve and maybe the image quality, how do you?
Mhm.
I think what you're asking is, can you go back and modify that program? How do you tackle
Mhm.
that?
Yeah, this is a really great question. And maybe I'll touch upon one of the questions in the Q&A, which is asking about how to prep a data set for segmentation, what it takes, making sure that these features are going to work and make them a bit future-proof is a huge challenge. But it's something that you also have to think about in the beginning. And it is absolutely an issue if you have a single protocol. So, for example, imagine a fixed set of timing parameters and spatial resolution, one vendor, one field strength. These things are going to have difficulty generalizing. There are different ways of handling it. The most obvious is to make sure you include diverse sets of data. And I think that's probably the most important part. And diversity across the patient population, the hardware equipment, the protocols you want it to support. There are also technology components that can improve performance. Data augmentations. If we go back to that example I showed where you get this complete failure with if you invert the colors, you can sort of think about these problems and these things in advance. You can start to do things by resampling your data initially. You can start to do things by rotating it, augmenting it. There are network architectures that are more stable to diversity. Um, I think the key element is to think about this upfront, to recognize that where you work and where you don't, to label it clearly, to recognize when you're going to start failing. The other component is to monitor performance. You need to be able to check when things are working well and when things are not, so you can actually see if there's drift happening in the field and deal with it. But future proofing it and making it diverse is certainly a challenge.
Great answer. Going back to the question section, I think I'm going to combine two, one from Johnny Liu and one from Fatima. So Johnny's is how can surgeons contribute to this whole process without introducing bias, but being helpful, i.e. adding in information about history and their evaluation methods, clinical examination, probably nerve conduction studies. And Fatima adds in, do you think AI could enhance early detection and prognostication in acute traumatic peripheral nerve injuries, i.e., guiding timing and type of surgical intervention? Now, we will be doing a webinar later in the year which looks at sort of what's happening with regards decision-making algorithms, but maybe I'll just open it up to the panel about does anyone have any particular how can we add our information as clinicians into your scanned images to see if we can create an algorithm which helps with reporting, say. Exune, oh, Daryl, go for it.
I'll take a first stab and then let it soon expand on that. Um, some thoughts. I think one of the Dr. Chabra, Ms. Chabra, took a lead in trying to create a structured reporting system of nerve abnormalities, and I think some type of structured reporting would be helpful for creating an AI algorithm for detection and again reporting. But I think while there was successes with that structured reporting, I think one of the things it did not incorporate, which I think is vital, is surgical feedback or surgical findings and also electrodiagnostic findings. So I think with any kind of interpretive study, I think the hardest thing sometimes with nerve imaging developing these tools is what is the ground truth. So being very clear about defining what is the ground truth as a way to determine the accuracy of a program. So we love surgical feedback. I prefer if it's positive surgical feedback to negative feedback in terms of, what I've described. But I think that's just a general answer to your question. Maybe Exo, you have other thoughts.
Yeah, one of the things that we encounter frequently, at least in our field, in MRI, is MR neurography is not it's not being emphasized too much, so it's not being paid attention to too much. So there's definitely a lot of potential for improvement, and I think definitely our surgical colleagues can contribute by having a louder voice and demanding for more research efforts and more better image quality, more efforts into improving the scan quality as well. I agree with what Dr. Seek says. I think a lot of that is through a multidisciplinary collaboration, being able for images like myself to understand the clinical needs. I think that would be of key importance. And from there, then contributing in terms of whether it's in defining the parameters the or even with image segmentation, that will be very tremendously helpful.
Keeping on that topic, Exun, you showed an image of Parsonage Turner in your presentation and a couple of sort of hourglass constrictions in, I think it was the suprascapular nerve
Mhm.
bilaterally. Did the surgeons go in and decompress that? And did you get feedback on findings and whether it was accurate?
I forget which case it was specifically. These are mostly read by Dr. Snee. I'll let him answer that.
Okay.
Yeah, so
Do,
no,
do, do you
not
get the
not for,
feedback?
yeah, not for that case. Most of the patients are not operated on, but we have published a large series with surgical findings. You know, patients who undergone neurolysis, and we found excellent correlation between the imaging findings and the surgical findings. Yeah, sometimes intraoperatively, particularly when there's a fascicular abnormality, so you don't have a constriction of the whole nerve, it may not be obvious, and the surgeon has to really trust the radiologist that and the image that the finding is there, because they have to do an internal neurolysis sometimes to find the constriction. But yeah, in general, we found excellent correlation between our imaging and intraoperative findings during exploration.
Because I think that's an interesting point because at the moment in my practice, the standard MRI is not a barrier to me to either receive a referral or often to make an operative decision. I get a standard MRI of a brachial plexus, very difficult to interpret what's going on there, whether there's any pathology. So my decision making will be largely still based on my clinical examination, the patient's history and findings. Obviously, with AI and the belief that these images are much more profound and if we see an hourglass constriction, I'm more likely to delve in and maybe operate on that patient. So you can see a shift where we're going to become a lot more reliant on MR neurography, sort of making the decisions. Do
Right.
you do you do you see a responsibility for yourselves with this and
Yeah, I
pushing
think we have
things
to
that
be
way?
honest and accurate in the reporting. I mean, every day I want to be able to push the spatial resolution boundaries, and I implore the vendors, since we're quite reliant on them, to create new software, new hardware capabilities to kind of keep pushing the boundaries. I think we're just touching the surface of what is capable. I think where MR neurography lacks is really in specificity. I think we're relatively sensitive to signal abnormalities, size changes, but being able to differentiate one entity from the another is where we're really lacking. So unless I see in a traumatic setting discontinuity of the nerve or frank neuroma, which refers to a disorganized attempt of the nerve to regenerate and becomes much larger, loses its vesicular architecture, I'm still left kind of in a quandary telling the surgeon, being able to, for in terms of prognostication, determine what the true severity of the injury is, and also to, in the setting of inflammatory neuropathies, be able to distinguish one from another. And perhaps maybe that's where AI will have a role, is because maybe there's some patterns that I don't immediately appreciate or haven't recognized when you put enough cases together and you have the input from electrodiagnostics and the clinical input to provide the ground truth. That's when you can really tease out these different entities.
Great. I'm going to move on to the final question on the question and answer session. So, from Blessings, how can you effectively integrate AI in the workflow for LMICs context and with language barriers?
Mm,
Which I think is sort of a general question. In the US,
mm,
big resources, lots of AI investment.
mm.
How is that going to sort of extrapolate across the world and really sort of hit maybe resource struggling countries? Do you have a view on how this can be opened up to the world? Exu, maybe you can start. Any thoughts?
Um, I think at least from the MRI standpoint, there's been interest to go towards a lower field strength magnets. And part of the problem with lower field strength is the lower signal to noise ratio. So AI has been used to in a similar methods that we have shown to improve the image quality and being able to see small structures, improve the resolution from there. I don't think it's there yet for MR neurography, but certainly being able to make MRI more commonly available, perhaps in more innovative outpatient settings with portable MRI systems, that could be one way to do that immediately, more immediately.
Wonderful. Any of the rest of the panel have something to add? Mark, from a sort of more corporate perspective, how do you think you can help sort of resource less wealthy countries, maybe?
hmm I mean, we actually are really hoping that AI, which is currently sort of a premium feature, but will as it becomes more adopted and accepted and standardized, will actually become an enabler for democratizing and enabling these systems that are less expensive, actually, because we can start to replace some of the more expensive hardware components like the field strength or lots of receiver chain elements. We can start to actually make systems that are more accessible, but are supported by AI, which will actually improve accessibility and break down barriers, including language barriers. So we do think that AI will play a really big role in that in the future. Right now, unfortunately, it is still sort of a bit of a premium feature as we try to recoup some of the investment in developing them.
Thank you very much. Before I bring the webinar to a close, I'll just invite the panel. Do you have any final thoughts? Daryl, any final thoughts before we close?
Just the final thoughts, just in terms of nerve imaging as a whole. I know we're focused on AI here, but I would just encourage really everyone, particularly surgeons on this call, to really embrace imaging, whether it's whatever you have access to, whether you have access to ultrasound, which is an extremely valuable tool, or MRI. I think the notion that, in the past, maybe that imaging would just be able to either you get a negative report back, or you'd be able to just exclude, say, a extrinsic lesion or a mass along the course of the nerve. Those are the old days. I think now with improvements in imaging, you should expect and demand more from the output of the scans. And when a patient has a spontaneous neuropathy, whether it's a sensory and particularly a motor deficit, before maybe going into the OR, I know certainly first and foremost relying on your clinical acumen, physical exam, electrodiagnostics. But I do think, just my experience of the last decade or so, that imaging can play an important role in kind of shaping your thinking about how you're going to tackle a patient during surgery.
Thank you for that. Right, well, we've just gone over the hour, so I probably will be bringing it to a close now. I think sort of my final thought would be, I think now more than ever, and particularly in the world of nerve injury, we shouldn't be working in islands, and sort of collaboration is key. We all recognize that data sets are the most important thing we have, and nerve injury is so heterogeneous, and actually so many clinicians see so few. We're often reliant on sort of centers like HSS pushing the field forward. But I'm sure with collaboration, we can move this field forward much quicker and produce sort of less biased outputs. And that's probably the direction of travel. And I hope sort of people will collaborate. And I'm definitely going to aim to try and work with HSS to try and help that along. So thank you very much for your time, Exun, Daryl, and Mark. Fantastic talks, in fact, fantastic input. And Stephen, thank you very much for organizing this as usual. We will be having a series of webinars on AI, with both on algorithms later on in the year and ultrasound scanning towards the end of the year. So I hopefully will see many of you again. Thank you very much, everybody.
Thank you.